What a debate. I am super impressed with all of you and your participation in this debate. This was a twofold um, assessment, so to speak, or assignment, meaning that I had two goals for this. One was to get you in the habit of participating in a professional debate. As educators, we are nursing leaders, and we need to be able to sit at the table and advocate and champion for not only the rights of nurse educators, but the role of nursing education within our health systems and within our academic programs. So, in order to engage in those discussions, we have to learn how to integrate our clinical expertise and professional expertise with what the scholarly literature says. Because yes, our insights are extremely valuable from the experience we bring, right? However, and it's molded by the experiences we've had. However, without that scholarly debate, it's just our opinion. It's not informed, so it doesn't carry as much weight. So that's the importance of bringing in that scholarly literature into something like this. Number two, I think these two pieces of the AACN 2021 Essentials are really important for educators in all realms of education, particularly academia and nursing professional development. When we talk about the 2021 AACN Essentials and this switch to a competency-based framework, immediately everyone's head goes to, well, this is really about academia. But I am going to challenge you all and say, absolutely not. If you are teaching in the clinical or NPD setting, you are directly impacted by the curriculum and the preparation of the learners during their academic journey. So with this transition, absolutely you're being impacted. And you need to be thinking about what happens when I have some graduates from a CCNE accredited that have gone through and have demonstrated attainment of these competencies versus those from the two other accrediting bodies that have not been in a competency base, so they've learned and they've been taught differently. And that's really something that you have to think about as educators. So, debate number one, we talked about the transformative curricular change that the AACN 2021 Essentials recommended, and that's that switch to a competency-based curricular framework. And listen, I am all on board for this because I think this is the missing link in our educational in nursing education for a while. Our medical colleagues have already been here. They've already been doing this. Nurses in Canada, they are taught through a competency-based framework. The difference is neither have the abundance of competencies that we have in nursing. But what does nursing do best? We muddy the waters, right? Let's just be honest. So, competency-based framework, what we see from the essentials is that there's level 1, which is undergrad competencies. Now that is our, BSN students or graduates and RN to BSN. And that makes it a little challenging because those nurses that are coming back from their BSN, they have to demonstrate these competencies by the time they graduate. So that's something that's a little hairy for us in the academic world trying to get all of them in. Level 2 competencies are masters and DNP prepared. PhD programs are not accredited by any of our accrediting bodies at this point. So it's really looking at our masters and DNP. What we're seeing with this transformative change is that it's a shift from content focused to outcome focused. So it's not about our learners being able to regurgitate all the content. It's about really them demonstrating what they can do. So that's where this whole focus on competency is the doing part, seeing our learners master these competencies. Okay, that's our goal. And something when we say competencies, immediately everyone thinks psychomotor. And I'm here to say that's not it. That it's not going to change. Your graduates are still not going to come out, most of them, and not know how to put in an IV. Your undergrads, right? Not know how to put in an IV. Or maybe be skilled at hanging Howland lipids. And the reason for that is many hospitals and health systems don't let undergraduate students do that in the hospital setting. So their only experience is in the lab and with the equipment we have in the lab. So keep that in mind. It will require us to change how we teach. And that's the exciting part of it. We have to get out of this dependence on lecture. Will there still be lecture? Absolutely. I flipped my classrooms, but I used lecture. Still, I needed that lecture because I needed to create that balance for learners. But it also requires us to rethink how we assess our students. It's not just about having them know what, but it's knowing them, it's that they know how to do it, okay? So the knowing what and showing how. So the opportunities for us as educators, man, like the innovative teaching strategies we can bring in here. I mean, I really see undergrad as relying more on flipped classrooms. I mean, that's the way we got to go. Bringing in more experiential learning opportunities. Now we have to think about this through a creative lens, because that doesn't mean pushing more students more into clinical, because we'll talk about that in a second. Those clinical placements are really tough to get. But with these opportunities, it gives us another opportunity to create a clear portfolio of what our learners are able to do. And this may look like the students putting together an electronic portfolio demonstrating the knowledge and skills that they have attained. So what is the outcome here? We're talking at Drexel about developing signature assignments. So at the end of each course, or certain courses, learners do a big project like your syllabus and your teaching plan. Those are signature assignments that is the culmination of all the learning in this particular course. Another opportunity that I think we're seeing here with the essentials, and I think will have a direct impact on the clinical practice setting and therefore our NPD educators, is that in undergrad, there needs to be a focus in the curriculum on the 4 spheres of care: wellness and disease prevention, chronic disease, hospice, palliative, and regenerative and restorative. Now, that does not mean that there needs to be a class for each. That means these should be threaded throughout the curriculum. So we're not so focused on acute care and then have our end of life course and think that's it, our students got what they needed. We took them through the continuum of life and health. That's not it. It's really looking at, what does it look like treating a patient to prevent heart disease versus caring for that patient with chronic heart disease, and what other morbidities have developed as a result of that and why. The challenges we are facing for level 2, there is 209 sub-competencies, which is absolutely insane to think in 2 years we can get all of our masters or our DNP prepared students through meeting them more than once. That is a challenge. So CCNE has recognized that as our accrediting body and said, let's just focus on the competencies themselves. And as a result of that, what comes out from a competency-based framework is that within our curriculum, we build what's called progressive indicators. These look a lot like learning objectives and are structured kind of like learning objectives because they're measurable behaviors. But what they do is show it's the direct behavior that we're looking at from our learners to say, yes, they're advancing from developing competency to achieving competency, and that's huge. And these progressive indicators will guide our assessment process because they are examples of students meeting these competencies. Now, these competencies must be threaded throughout the curriculum. It's not like, hey, we have a competency or a domain on informatics, so let's just create a class around it. I mean, yeah, sure, we could have one little class around informatics. We could develop an entire course around informatics. But that's not what competency-based education is. Competency is threading it throughout the curriculum so students are introduced to it in varying contexts and at various levels. And that brings us to the multiple opportunities for assessment from different assessors. So it's not being just graded or assessed by the same educator in the course on informatics, but looking at how we're assessing that developing competency throughout the curriculum. There's something interesting here and something to think about is that there's no minimum required hours for clinical in level 1, so for our undergrad, in terms of they need to have at least this many hours. Now, some state boards of nursing have a specification on that, as well as the role of simulation. but not all state boards do. What I will tell you is for level 2, there is a requirement on clinical hours. So for master's level, anything that's not NP, it's 500 clinical hours, and these can be direct or indirect hours, and we'll talk about them in a minute. Whereas NP, they need to have 750 hours, which is quite a lot. And that's from their governing body, which is the National Organization for Nurse Practitioners, or what we call NOMF. So this really has required us to rethink our entire curriculum and really transform it. But something that we still have to think about is what happens when an applicant for an MSN program did not graduate from a CCNE accredited BSN level program. Like, how do we accept them? Because they need, from when they enter a master's, they need to have met these competencies. So that's something that we're still grappling with. And this is going to affect the NPD setting, because you're going to have graduates that are still coming out from different programs, so their competency level will be different. And that's one of those big obstacles. Another one with this curricular framework is clinical placement opportunities. We talk about experiential learning, and isn't the ideal place where we most think of is let's do it in clinical. Well, the clinical placement opportunities have shrunk since COVID, so it's become extremely competitive. And the other piece that many of you brought out is clinical doesn't necessarily assure that our learners are getting the same level of education or experiences or exposure or practice, right? Access to simulation resources. We talked about this in the beginning of the course. Every program looks different. Again, this is where partnerships with the NPD setting can really help, because is there a simulation lab? I know in the program I taught at, they had a beautiful OB sim lab in their OB department, but we weren't allowed to use it with our learners. It would have been great to pull them out of clinical one day when there was no babies delivering. Let's do a quick simulation. So it's really important to kind of structure those partnerships. And something that's really, really important here, and this is really important for us to think about as educators and also educate our nursing staff in the clinical side, and this is, again, something important for our NPD specialists. There is a huge difference between demonstrated competency versus competent. So if we go back to Benner's novice to expert, it takes 2 to 3 years for a nurse to reach the competent level, according to Benner's theory. I think we could probably all agree with that, right? When we're working with new grads, even our first year, I definitely wasn't competent, right? Now, when our learners are graduating from a competency-based program, they are not competent. They've mastered specific competencies. Okay, so that is something, that's a language we have to get used to, and it's something that we have to train our preceptors and our staff on, because there's a lot of, oh my gosh, I can't believe these students don't know how to do this. Well, that's not necessarily part of an undergraduate curriculum. So thinking about that. And this is what I was talking about. Graduates are still entering with varying levels of knowledge and set of skills because we have different requirements from our accrediting body. The other thing to think about, and I know this is a huge thing, we all want to get rid of objective testing, right? I know, again, we talked about this in our opening discussion boards way back when, but there still is a need for knowledge assessment, and objective testing is the way to do that. And even in competency-based, we need to establish that foundational knowledge. And usually it's these objective testing that we can do that. That still demonstrates that they're developing competency, that foundational knowledge, which is needed for them to master competency. And think about it. What do you think the feasibility is for having a professional licensure with simulation? They've been talking about it for 10 years now, but thinking about how we bring all of our learners into a simulation, now is that something that's required at the program level? Maybe potentially that's something we could think about, but at the professional state board level, I think that would be really difficult. So debate number 2, and this one, let me tell you, this got my blood boiling back when they first announced these essentials. The nurse educator being recognized as an advanced nursing role. Now listen, everyone, cool your boots or cool your heels, whatever that saying is, because that recognition is there. CCNE looked at this and took, honestly, I will say, a lot of feedback from educators in academia and the professional setting, and wanted feedback from them. And what came of it was, okay, we are going to keep MSN in nursing education programs because there's a need for it. But they've looked at how can we structure this to ensure that there's disciplinary expertise as well. And the irony of all this, which I love to share, is that through this entire curricular transformation, which is huge, huge, like it would take me a week to even walk you through what we've been doing here at Drexel, but who is at the helm of this transformation? I will tell you, it's nurse educators that have a background in education or nursing education. If you don't have a background in curriculum development, teaching, best practices in teaching and learning, assessment and theory around assessment, it's going to be really hard for you to transform a curriculum without that knowledge. So it's the educators that have that knowledge that are really at the helm of this, which is, kind of funny in my mind. So AACN's initial recognition was that advanced level nursing programs with an emphasis on teaching and learning do not fulfill the achievement of advanced level disciplinary expertise. But here's my challenge to that. What advanced level disciplinary expertise are we looking for? Because right now, in my role, my disciplinary expertise to really be beneficial to all of you needs to be in nursing education, not necessarily the nursing discipline at this point. However, I want to keep my skills up in nursing. That's not to say I could walk into a NICU tomorrow and be like, hey guys, I'm back, I'll go to every delivery, give me the micro preemie. No, I'm going to need a reorientation to that. But I do what I can to make sure I can stay up to date on those critical changes of my discipline. CCNE standards are like, okay, listen, we're going to continue to accredit master's in nursing education programs. However, they need to still include the 10 domains and the concepts and 45 competencies, but they also need to include advanced level disciplinary knowledge and skill set. That is not to say advanced practice. The educator role is an advanced role in nursing, just like that of leadership. So, interesting, and something that many of you brought up is that, we should have advanced disciplinary knowledge. Let me tell you that we already do, and that's a CCNE requirement. You have the choice in an MSN program, leadership, informatics, nursing education, to either integrate. Actually, it's really about, there's a heavy emphasis on nursing education. But anyway, you need to incorporate the 3 Ps, pharm, patho, and health assessment, in some way in the graduate level master's program. That's not to say they need to take 3 individual courses. Some programs do that. However, that's a financial burden, or that's additional credits, and it takes away from credits around education. What we've decided at Drexel is that we are going to create a course, it carries a higher credit load, integrating these concepts, and CCNE suggests that. So rather than 3 individual courses, we have 574, which is Advanced Integrative Concepts, which gives our master's level students, particularly in nursing education and leadership, the opportunity to apply their disciplinary expertise in these advanced situations and concepts and those type of things. So we have that course. In nursing education, you also have to do hours with a direct care patient experience. That was another requirement. Leadership doesn't need that, but nursing education does. So timeline for implementation, this came out in 2021. AACN suggested there was going to be a need for a minimum of 3 years to do that. CCNE said, okay, by January 2025, you can start integrating the essentials. You don't need full implementation. So, but we needed to show, and we are showing here at Drexel, how we're going about adopting the new essentials. And our transformed curriculum, our transformative curriculum, will be launched in fall of 2027. So thinking about the role of the educator, something to think about for all of you is we have to educate learners within their scope and standards of practice. So if we are teaching undergraduate, we can't be teaching them at the level of NP. That's not within their scope, right? So putting more pressure on them to have advanced knowledge, or us coming in with advanced knowledge, expecting them to meet us there, we can't. Same thing with an NPD specialist. You're getting a graduate from a generalist program. So if you are hiring them into a specialty role, it is the health system and the NPD specialist and that team to give them the education to help them specialize, okay? To teach at the NP level requires an NP. If you're teaching at the DNP level, you need to have a doctoral degree. The goal is always to have one degree higher than what you're teaching. So technically BSN, they need to have an MSN. I will tell you, because we are inundated in this area with educational programs, most in academia are required to get a doctoral degree, even to teach at the undergraduate level. And you may not need it upon hiring, but you need it within a certain amount of time. NPD specialist, if you were to sit for that certification, you have to have 2 years practice experience, so disciplinary experience, as well as professional development experience to sit for that certification. If you don't have any background in teaching and learning, it's going to be really hard for you to assimilate to that role. So that's just another thing to think about. If you have not read this, I know it's old, but this is so interesting. You can go to educatingnurses.com. We've used this in our course, but that's the Benner website. Make sure you use your Drexel email address, save your password, because I have this integrated in other courses. But this is such a valuable read because this came out over a study with nurses back in 2009, 2010. And it talked about how we need to transform nursing education. And you've seen a little progress along the way, but now here we're finally, 15 years later, jumping into competency-based. A little preview of what's to come. This is how we're integrating the essentials into our future program, our MSN in Nursing Education program. Initially, we weren't going to have a nursing education practicum because we didn't think CCNE was going to allow it. But since they did, we're keeping our nursing education practicum. But what we've had to do is increase our hours from a total of 160 over 2 quarters to now a total of 240, 120 and 120. We are also flipping to a semester-based program here at Drexel. That's university-wide. That was not related to the essentials, but has really impacted how we can kind of meld our courses together. So you'll see some of the core courses look familiar. We've combined health policy and ethics, research and evidence-based practice, and here's our advanced integrative clinical concepts. That will have practicum hours, just not direct. It'll be experiential hours that students are doing it within the classroom. Our learners will now get the AACN competencies through leadership courses. So we have a core group of leadership courses. These titles are going to change because we've refined these courses a little bit more so that they have the leadership component, but also are interesting and not so heavy into, they're heavy into leadership, but it's going to have a spin so it kind of looks interesting to educators that might not want to take a leadership role. Okay, but graduates will get a leadership certificate, and there will be experiential hours in this, in these courses. And these are not in the practicum setting or clinical setting, but they are going to be through experiential learning opportunities. Our nursing education courses, again, these titles have changed, but you'll see that we've combined some courses. So teaching methods will have in there the online teaching and simulation. Our curriculum course, this course, will also combine with the assessment and evaluation. And then we'll have 2 semesters of the nursing education practicum. So I hope that helps a little bit. This is way longer than I wanted it to be. I'm sorry, I've recorded this twice and I can't get it down. But I thought this would be really helpful to kind of clarify some of the pieces for you so you have a good foundation moving forward. If you have any questions or concerns or would love to share any additional insight related to this transformation, please don't hesitate to reach out.